Thank you so much for attending my talk. I know there's also an interesting talk in the next room, and I'm just so happy that you're willing to come and listen to mine because, quite frankly, we're still in the middle of COVID. And while the rest of the country thinks we're done with it and everything, new news and new information is still being generated on how the pandemic is continuing to affect our society. And the good news is we know a lot more about what we're doing in COVID patients and what works and doesn't work. The bad news is we're going to have to use that knowledge for the foreseeable future, most likely for the next couple of months to years, because we are seeing new variants come out and it will impact us as healthcare workers. So I'm going to talk about a topic that nobody else in this country is talking about. And the reason why I'm doing it is because it's very, very impactful to respiratory care and our practices and the patients that we see. There's a reason you've never heard this topic talked about here in the United States. And unfortunately, we've paid a heavy toll because we've tried to cover this problem up. So bear with me. A lot of it is information you already know. But for some of the students in the crowd, I hope this opens your eyes to respiratory care and really imparts with you how important it is for the patients that we serve, because there are no more vulnerable patients than the ones who are on long-term mechanical ventilation. That is a period of time in everybody's life when no matter how rich you are, how powerful you are, how smart you are or accomplished you are, somebody has to care about you intensely to have good outcomes. And that's what respiratory care means for those patients. So full disclosure, I run a little medical device company. We make airway management devices. If you're interested in learning more about that stuff, we have some cool stuff coming up, but I'm not trying to influence you to do any of that. I'm here to just talk about the topic at hand. And just like many of the other speakers who have talked to you over the course of these 2 days, we are all very appreciative of respiratory care. The whole world recognizes the immense impact that this profession has had on patient lives. I see these kind of headlines all over the place, and most of us are too busy to pick up a newspaper or open our phones to see this nowadays, but there is no doubt that now you can hold your head up high and you can tell people, I'm a respiratory therapist, and they will know what you do. But the fight isn't over. Just yesterday, the WHO basically came out with new information that the death toll from COVID-19 was 3 times more than what was reported. And they point to India and they say that there's significant underreporting. And I will guarantee you that's the same fact that's happening still in Africa, Asia, and other countries in South America, okay? We won't know the true toll of this pandemic until many years after this has been more resolved. But to this day, there are respiratory therapists and care practitioners abroad who are still fighting the good fight, and they're getting burned out because basically our governments are not protecting them. And we have to do everything that we can to support our colleagues abroad too. So just to recap, during the pandemic, we learned a lot. We learned that when you intubate patients early with COVID-19, it's not good. They have bad outcomes. We're trying not to do that. We're actually trying to do more non-invasive mechanical ventilation. You all know that. And this is one of the interesting things about the early intubation problem. It made outcomes worse and increased mortality rates in these patients, and that's why we're not doing that. We figured out that delaying intubation and delaying invasive mechanical ventilation in general increased survival rates, decreased the amount of mechanical support they needed, and more people went home. And now it is standard of practice when you see COVID patients to use high-flow nasal cannula whenever you can, to do basically non-invasive mechanical ventilation as much as possible. And if absolutely necessary, to split the ventilator circuits. Um, but this is a chart I saw in early 2021 um, from the Wall Street Journal, and it chronicles what has happened during the pandemic. This virus has mutated immensely, and unfortunately, since this was published, they don't publish this anymore. There are no new charts about how many mutant variants are out there because it is very unpopular to do this. Because once people know that, okay, the situation out there is that there are new variants coming out basically every week, and we're tracking them, and we're doing that, then the pandemic may not be over so quickly. Um, it's very distressing for a lot of people, and unfortunately, we're probably not going to see more of these charts anytime soon. But the point that I want to impress upon you in this was when COVID was basically in its infancy stages, and there were less than 50 million people infected, which means there were less than 50 million people with the chance for a mutation to be caused. Today, the best estimate of how many people are infected with COVID is in the billions, active cases. And so you could multiply this by 20, and you could get an idea of how many of those mutations are happening right now. And that should really concern really all the public health institutions around the world. But I'm here to talk about one interesting thing that is universal in all of these variants that really cause disease, which is COVID patients, regardless of the variant, get ventilator-associated pneumonia. Now think about that. Just like every virus, every coronavirus out there that's been a mutant of this is in the air. We know that we have to wear PPE, and we have to wear masks, and we have to do everything we can to prevent spread. Every one of these variants out there caused ventilator-associated pneumonia in high numbers, which means preventing ventilator-associated pneumonia in these cases is just as important as PPE, wearing a mask, social distancing, all the things that we've done many times successfully, many times not successfully to prevent spread. But if this is happening in all variants, then we can expect this to continue in the future when we have other surges. The issue here is we're not tracking these infections here in the United States. We're not even talking about it. It's the rest of the world that is producing this data. And what we know is when there is infectious Klebsiella or Pseudomonas in the ICU, when we have MRSA pneumonia, and we have Aspergillus and Candida, these aren't normal community-acquired pneumonias. They don't act the same. They aren't treated the same. And many of them are already antibiotic resistant. And so we know these are ventilator-associated pneumonias that we're just not talking about here in this country, but the rest of the world is, and everybody is taking note that even when these patients go on ECMO and we do extraordinary things to save their lives, many times the cases of sepsis on ECMO, many times respiratory failure, is not just because of the virus. It's because there is something superimposed on top that is causing significant havoc in these patients. And I'll go over the data about it. But first of all, I want to talk about the incidence, because this is so fascinating. This is a chart that was published in 2021, early 2021, from a group of doctors in the UK, where they only track ventilator-associated pneumonia. And what they were finding is the average rate of ventilator-associated pneumonia in COVID patients was two times what we see in the sickest influenza pneumonia patients. Once those patients got on mechanical ventilation, they contracted ventilator-associated pneumonia at twice the rate of some of the sickest patients we would normally see in any given year. And what's worse, this period of time, that first 2 weeks, right here, that's when they got it. And you can draw a line through that, and you can see right away that there's a relationship between the amount of time they spend in the first couple of days and the incidence of pneumonia. And afterwards, when we started to, and in Europe this is common practice, they start to trach people after 2 weeks. That incidence dropped dramatically. But this first 2 weeks, that incidence of pneumonia was pretty high and pretty consistent. Now, why should you care? Why should you care? As respiratory care therapist, why should you care? You don't write the antibiotics. You don't call infectious disease. You don't necessarily do the bronchoalveolar lavage. Why should you care? Well, turns out this is a big problem in terms of the amount of care that you have to provide. Because once a patient gets ventilator-associated pneumonia or any other kind of hospital-acquired pneumonia, their length of stay jumps, on average, 15 days. Their mortality almost doubles. The time they spend on mechanical ventilation, the number of days of that specific patient increases an average of 2 weeks. So everybody in this room who had a patient who the doctors were saying it was COVID lungs, they weren't getting better, they had VQ mismatch and we didn't know why. They were on antibiotics to begin with, and maybe they had a CPIS score of 7 or 8. A CPIS score of 7 or 8 is almost completely pathognomonic for ventilator-associated pneumonia. They didn't call it. They didn't try to address it. And what happened was respiratory care therapists, just like you, ended up having to basically try and take care and resuscitate these patients, get them off the ventilator, which was almost impossible many times. And we all have third-degree burns because we saw patients where the diagnosis wasn't clear. And unfortunately, they never got off the ventilator. This is a study done by a group of Italian doctors. And remember, in Italy, they don't get penalized for this. When they diagnose it because they want to treat it. There's no penalties, there's no consequences. They're just trying to do the best that they can for their patients. They're not necessarily looking very hard, but this is what they saw. 45% of patients developed a pneumonia. And if you're wondering, how come you have more cases of ventilator-associated pneumonia than you have number of patients, it's because those patients got 2 types of pneumonia. Many times you have polymicrobial types of ventilator-associated pneumonia where you diagnose one thing and then you find out later that something else is growing down there, and then you call it another case, and that's what they were seeing. What's also really stark about this is in this study, they figured out that cases of sepsis, they attributed about 30% of the sepsis cases to ventilator-associated pneumonia in this case, where somebody got pneumonia, they confirmed it was some kind of bacteria or fungus, and then later on they developed sepsis with the same agent, and they classified it as a bloodstream infection. And ultimately, we all know that those patients didn't do well. What's also very interesting is these aren't the only studies. There's a lot of invasive aspergillus out there that people are reporting, but they're not calling ventilator-associated pneumonia. And many of these studies are coming to the same conclusion, which is COVID-19 patients are particularly susceptible to this type of infection. And as respiratory care practitioners, you know why. They spend a lot of time on mechanical ventilation. They're immunocompromised because we give them high-dose dexamethasone. Many of them already have underlying conditions such as diabetes and COPD, which means they weren't healthy to begin with, and then they got sick. Obesity seems to be also a significant risk factor for these patients. And what's interesting is that led to significant mortality. And this is actually 5 different studies put together from a colleague at UCSF. Early on in 2020, he put together the best quality studies, and he found that in COVID patients, again, the incidence rate increased to about 45 to 50%. But what's really concerning is it added another 50% mortality rate. In the ICU, that kind of mortality increase is the same as kidney failure. Having an organ fail in your body is the same as getting VAP in these patients. And that's pretty unbelievable. But what's really unbelievable is VAP is not this new idea. It's actually a really old idea. We've known about this, and prior to some of the new definitions out there, we actually did a lot of research in this country on ventilator-associated pneumonia. And what's really interesting about this is this is an old paper about 15 years ago, and this is how ventilator-associated pneumonia happens. And these authors basically said we really shouldn't call it ventilator-associated pneumonia. We should call it endotracheal tube-associated pneumonia, because every time we put an endotracheal tube into a patient that needs long-term ventilation, their risk of ventilator-associated pneumonia goes up 600 to 2,000%. This is the smoking gun. And these authors actually spelled it out really, really clearly in this chart. They basically said bacteria grow in the mouth and the nose. You put an ET tube in there, and now this stuff will start to basically accumulate right above the cuff balloon. It leaks into lower airways, and then it forms biofilms inside the tube and pneumonia down in the lower airways. And we have strategies to do this. But what's interesting is even some of the prevention bundles don't include all of the strategies. They just kind of pick and choose what is easy. But if we were serious about this, what should have happened during the pandemic is we should have doubled down on these prevention strategies to reduce pneumonia. We should have figured out ways to make sure that patients receive the same kind of prevention bundle that they usually do when we're normally staffed. And we basically should have published more articles on what we were seeing. And you know the story. Fluid, you put somebody with a breathing tube in, you paralyze them, they can't talk. They're still generating all of this mucus from the back of their throat, and it accumulates, it gets into this space, and lo and behold, it leaks past the cuff and into the lungs. If you ever put a bronchoscope down a patient's throat and looked in the ET tube, that ET tube is moving when you're ventilating that patient. You push air in, the cuff moves up. You let the patient, you let the air out, the cuff goes down, okay? So it's not a static system, and anybody who tells you that you can use a low pressure, high volume cuff to create a perfect seal in the airway doesn't know their physics. It is literally impossible to do that, okay? It's better than having a very having no pressure in that cuff and having it basically almost deflated. But if you're saying you can create a cuff that seals perfectly to the airway to fluid that can basically push past that low pressure cuff, you're out of your mind. It is literally impossible. What's also interesting is, if you look in the clinical literature, we saw a lot of these types of infections. Ventilator-associated pneumonia looks nothing like community-acquired pneumonia. You don't see Pseudomonas and Klebsiella pneumonia in the community. You don't see a Acinetobacter or a Proteus or some of the really exotic ones where you really need a ID consult to take care of. And the question is also, how did we get here? Because this was not just a clinical problem. This was a political problem. And unfortunately, the CDC failed respiratory care therapists and the ICU and critical care on this specific policy. Because what we did is in 2009, we knew VAP was hard to diagnose and was hard to track, and we were asking people to do it. And it was killing people, and it was causing a lot of economic and clinical harm to our hospitals. And we knew there were a lot of cases. But Medicare stepped in and said, we're going to start penalizing hospitals for having these cases. So what happened? We stopped reporting it. When CMS told hospitals, if you have these infections, we want you to try and solve this problem, address this problem, do the best job that you can. Otherwise, we're going to penalize you. Hospitals said, oh, yeah. So it's ill-defined. Not everybody needs a chest x-ray. Not everybody needs a sputum culture. And if we institute policies where, the physicians aren't basically ordering these tests, we're not going to report. And so the incidence rate for VAP reporting in this country dropped by 85%. And many hospitals to this day will claim, no, we have no VAP. And then you'll talk to the people on the floor and they'll say, yeah, well, I have 3 right now. But that's not the end of it. because there were still honest hospitals reporting it at that point, and people were still taking this very seriously because they're saying, I don't care if the surveillance is there, because people are still dying. Well, CDC got together with CMS and everybody, and they said, we really need a good definition for catching VAP and also all these other things that are happening in hospitals, so that we can basically do some surveillance and know what's going on in the community. And so without any clinical data, without any clinical proof, a group of consultants got together and created ventilator-associated events, with the intention that ventilator-associated events would capture all VAPs, all ARDS, all pulmonary complications, and that increasing ventilator needs, such as increased PEEP and increased FiO2, would somehow capture the picture of somebody who was decompensating and getting worse and needed more therapy. And that's not necessarily true either. And so what happened was, they created this definition, they handed it out to everybody, we tried to adopt it, it was a little bit more complicated, but for the most part we could do it. And unfortunately, the rest of the world didn't follow that. They looked at what we were doing and they said, that's crazy. Why would you lump in ARDS with an infectious pneumonia? That doesn't make any sense. These are two different entities, they're going to behave differently, and your definition by itself may or may not encompass the problems that we want to track. So what happened was, we came up with all these definitions, and lo and behold, the reporting again dropped. And when basically the best minds in ventilator-associated pneumonia research saw this, they went digging and they wanted to see whether or not this definition really captured what was going on in the community. This is a 2016 study, and what they did is they looked at the rates between 2005 and 2013 in terms of the clinical outcomes of patients. So if we had decreased ventilator-associated pneumonia at that point, the outcomes for patients should have gotten better. And because they did it all the way from 2005 to 2013, the study was very powerful. The results were very conclusive. And what they found was the rates didn't change. They concluded that it was all reporting. We weren't catching, we weren't diagnosing, we weren't reporting the cases, and nothing statistically significant had changed for patients on mechanical ventilation. I think that study was done on over 30,000 patients. So looking in the literature, turns out they weren't the only ones noticing this. Our friends in Europe and in the UK were also looking at this definition of ventilator-associated events and wondering, hey, does this work? Can we do some retrospective research? Because they were tracking VAP, so they knew where the VAP was. And so when they took our definition for ventilator-associated events and applied it to that population where they knew where the VAP cases were, this is what they found out. The definition for ventilator-associated events, infectious ventilator-associated complications, captured less than 18% of ventilator-associated pneumonia, which means it missed more than 80% of the pneumonias that were occurring. VAE is not a good measure for VAP. It is measuring something entirely different. And so what we've done in this country is actually decided we're not going to measure ventilator-associated pneumonia. And the definition for VAE is not nearly perfect. It creates a lot of havoc already for respiratory care. These are two friends of mine who I asked for some anecdotal evidence of what they had seen with the VAE definition. And what happened was, one of them said, we start everybody on 8 PEEP now. For no good reason, except that, if I start them on 8 and I go down from there, nobody has a VAE. And another respiratory director came to me, I talked to him, and he said, I'm really frustrated with the ventilator-associated pneumonia, ventilator-associated event definition, because when I get a patient who's admitted at 11:30 and my therapist can't get to the ventilator and change the settings by 12 o'clock, by that time, that patient actually has a ventilator-associated event. because that first 30 minutes of admission counts as a day. And that makes no sense. And so we have, in one case, a place that is not being penalized, but not doing very much for ventilator-associated pneumonia prevention. And we have another place that is trying to do their best, but they're getting penalized because of the time the patient gets admitted. That makes no sense. That has no bearing in whether or not this patient, this facility is providing good care or bad care. So what can we do going forward? I'm just going to talk about some of the ventilator-associated pneumonia prevention strategies that we already know, but that reinforcing them and training on them and actually looking at some of the hospitals that are innovative in this space can really make a big difference. Okay? These are basically an expansive number of different types of interventions to prevent ventilator-associated pneumonia, and I organize them in the fashion in which they're modifiable. Because in respiratory care, we do most of this, and we do almost none of this. And these are some of the places where if you can modify and increase the aggressiveness of your treatment, we might be able to prevent more of these pneumonias. I'm almost certain we can because I've run into some of these facilities that are doing exactly this. So obviously, the best thing that we can do to prevent ventilator-associated pneumonia is getting them off the ventilator. That will be always the paramount strategy for preventing this type of pneumonia. If we can avoid invasive mechanical ventilation, if you can avoid putting a breathing tube in place, if you can avoid a paralytic, the patients are going to do better. But many cases, it's unavoidable. We know now we don't want to switch the circuits unnecessarily. Back a number of years ago, we were doing this daily, and that turned out to actually increase the risk of pneumonia. Now the guidelines basically say you want to look, if the circuit is soiled, then you can change it, but otherwise every week to 2 weeks. Head of the bed. The actual studies on head of the bed were actually at 45 degrees. 45 degrees is basically undoable. So everybody is telling us to do it at least 30 degrees. And one of the best strategies for this is, in every patient's room, you can take a piece of electric tape and you can basically tape it on the wall to figure out exactly where that bed is 30 degrees. And when you walk in a room, it's very stark that you can see that line. And if the head of the bed isn't above that line, you know you have to readjust the bed, because when you're not by the bedside, you're going to have people who move the bed, change the position, and you want to consistently keep that head of the bed above 30 degrees if possible. Okay? Oral care. I know there's been some controversy about using chlorhexidine oral care. There is some association with increased mortality with chlorhexidine, but quite frankly, the proof is very solid that this reduces the incidence of ventilator-associated pneumonia, and training on this is worthwhile, because when you train on this, the quality of the oral hygiene increases. And this is one of the places where there are actually some new developments coming down the pipeline. You will start to hear about new devices and new approaches to actually do this more effectively. Cuff pressure maintenance. We know that when cuff pressure is below 20 centimeters of water, that increases the risk of microaspiration, aspiration in general, but it also increases the risk of ventilator-associated pneumonia subsequent to that. There is no proof that if you go too much higher, that if you have higher pressures, that it does any better. So monitoring the pressure and keeping it above 20 centimeters of water has been proven to be important for ventilator-associated prevention. Okay. Aggressive sedation interruption and extubation. This was not always possible in some of these patients. If you had a patient who was satting 70, 80, extubating them early wasn't going to help them. But in normal times, this has been a really important strategy. Most places in the past have not been aggressive enough in terms of figuring out when to take the patient off and give them a breathing trial to see if they can be off the ventilator. Now that we're in a different place, this is also a strategy that you want to revisit to look at your existing protocols and see if early weaning can be done earlier in the day or more consistently. Oftentimes, when you have a shift handoff, that's when this type of interruption, this kind of practice gets delayed. Early mobility. This is a very interesting place of research because we know that when we get a physical therapist involved, and I know most of you haven't seen this here in Florida, but when we get them involved and we get the patient out of bed, even if they stay intubated, their risk of pneumonia drops dramatically. There is actually a hospital in Utah that does a lot of this, where they walk these patients who are still intubated. And it's a very interesting place because they're part of a bigger system in Utah, but their rates of complication and their cost of providing mechanical ventilation is basically about half of what their sister institutions are doing. And if you like a reference, I can give you the name of people to talk to in Utah about that. I'm a little partial because I make a tube that does this, but remember, the root of the problem is the endotracheal tube in the airway too long and these secretions that accumulate. And the strategy of providing tubes that can kind of prevent that aspiration has been, the evidence has been positive and negative in some factors. There's a lot of myths behind these devices. Many of the myths you'll hear are, hey, look, I have a better cuff. The cuff is going to seal the airway better, and you're going to get less microaspiration. That has never been proven very well. What we have a lot of is these kind of demonstrations in plastic tubes where the tube isn't moving, you're not ventilating something, and that doesn't look like a trachea to me. When we do animal studies and we look at what these cuffs do in animals, and we put a little dye in the oral pharynx, what we find is after about an hour, all the cuffs will leak. About an hour, you'll have 9 out of 10 cuffs that leak. After 2 or 3 hours, you'll have 100%. So while cuff pressure is important, it's not the end game. And you cannot rely on cuff pressure as the only preventative strategy in this case. Now, this may surprise you, only about 10% of hospitals here in the United States use subglottic suctioning. It's recommended by a lot of societies, but what happens is, if there are no penalties and there's nobody who is tracking this, it's very easy to say, I don't want to buy a more expensive tube. I want to use the one the anesthesiologist recommended. But they're wrong in this case because airway management doesn't end when you put an ET tube in or an LMA in or a tracheostomy tube in. That's just the beginning of the battle. As respiratory therapists, most of the work and most of the complications are on the back end when nobody's looking. And that's where, better airway devices, in my opinion, can make a big impact. If you gather nothing else from this talk, this is what I want you to remember. There's a lot of VAP in COVID-19. Whether you report it, whether they want to talk about it, whatever, the data is very conclusive. There are over 100 studies at this point that tell us there's a lot of ventilator-associated pneumonia in COVID patients, okay? What is also very apparent is in these patients, ventilator-associated pneumonia causes additional mortality, appreciable mortality, okay? And it increases length of stay, time on mechanical ventilation, and stresses your hospital tremendously in terms of supply of critical medical therapeutics, devices, equipment, and staff. So this is one of the end results of that. And so it's not, we always hear that thing, A equals B, B equals C, so A equals C. What I'm saying here is, if we do a better job at preventing ventilator-associated pneumonia, if we pay attention to it in this population, it is the same thing as figuring out a way to decrease mortality. And that should give you all a minute of pause, because that conclusion, nowhere else in the world has come to this conclusion. Everybody is dancing around this, dancing around this. We aren't even talking about this. But this is what these studies are saying. If you can prevent ventilator-associated pneumonia in COVID patients, you can reduce their mortality rate. You can get them off the ventilator sooner. You can get them out of the hospital sooner. And as a consequence, your hospital, your staff, burnout will be a lot better because we won't be seeing as many patients die from this. So thank you very much. I believe I have a little quiz so that you guys have some, Now, I want to warn you because the quiz was from data that was pre-COVID, so I don't necessarily agree with everything now. But this is always kind of fun. So, ventilator-associated pneumonia is in a critical ill patient increases A, risk of mortality, B, length of stay, cost of care, D, time on a ventilator, or E, all of above. Anyway, that's an easy one. This is a little tougher. Ventilator-associated pneumonia increases overall length of stay by, don't worry about this, 28%. And that's across all patients. We average that. So normally you may have an average length of mechanical ventilation, length of stay of like 3 days. Add 28%. That's what ventilator-associated pneumonia will do. It's not every patient. It's that one patient that'll stay for 2 weeks. Which of the following is not a risk factor for acquiring ventilator-associated pneumonia? This was done pre-COVID, so please forgive me. Continuous sedation, aspiration of oropharyngeal or gastric contents, prolonged mechanical ventilation, or reduced clinical staff. Reduced clinical staff. That's not true anymore. That's not true. Because I knew one place in California where there was one therapist for 20 patients, and I can guarantee you, they did not do better than the place that was 1 for 6, okay? Which of the following is a risk factor for acquiring ventilator-associated pneumonia? A fever greater than 38 degrees, altered mental status for adults over the age of 70, or a new onset purulent sputum, or all of the above. All of the above. All right, this is the CPIS score for us pulmonologists. So components of the VAP care bundle include all of the following, except elevation of the head of the bed, regular oral care, making sure patient movement is limited widths on the ventilator, and or D, sedation, interruption, and assessment for readiness for extubation. See, that's correct. That was a smart group in here. Okay, if you're paying attention in the talk, to reduce the risk of ventilator-associated pneumonia, the head of the bed should be placed at D, correct. Effective oral care should be done at least daily. There are some places that still do it only once a day, but yes, I agree. Twice a day is better. Microaspiration can be reduced by early mobility, sedation interruption, effective subglottic suction, or D, all of the above. All of the above. You guys did great. Thank you so much. I hope this was enlightening. This is so interesting because prior to COVID, the only time you would really see a prone patient for mechanical ventilation in appreciable numbers, these were neurocritical care patients. They had had neurosurgery and they proned them. And it wasn't because we were afraid of complications or we had to they had trouble ventilating these patients. It was a secretion management strategy. So if you talk to a neurosurgeon, he'll tell you, yeah, we prone these patients after surgery because when you operate on the central nervous system, they create these copious, thick secretions that are very hard to manage post-operatively. So what we were doing to prone them. I know the data behind the proning practice. Seems like they're talking about these patients seem to aerate better and they ventilate better, and we don't honestly know 100% why. And the idea was that maybe there was too much material in front of them and they were having an easier time to breathe. I don't know about you. I sleep on my side or my back. I almost never sleep on my front. I don't necessarily feel like I breathe any better. In terms of intubation, we found out that intubating these prone patients didn't actually make improve their outcomes too. So I don't know if I answered your question correctly. Yeah. This was the interesting thing was this is a practice to prevent aspiration post-operatively that we just kind of employed. We knew they were ventilating better, um, but at the same time, we didn't ever come to this examine the fact that maybe they had less VQ mismatch because maybe they had less microaspiration in this case. Remember, when you see a patient who drowns, it only takes 150 cc's of fluid in their lungs to drown them. So what we're talking about when we talk about VQ mismatch is we're probably not talking a huge amount of volume of fluid. We're talking about a small amount of fluid that gets into the wrong parts of the lungs where we have gas exchange, and then we can't ventilate them very well at all. And that's something, I mean, was pretty consistent with COVID patients, whether they're prone or not. We don't know. It's one of those studies where they had it's an associated study where they said the patients who had more chlorhexidine mouthwashes had higher mortality. But we don't know why. It could have been that these were sicker patients to begin with. We don't know. But that's the real controversy is people are asking, should we do chlorhexidine washes? Well, try not doing it and you see what the mortality is. And that's going to be even worse. I've seen a patient who was basically circling the drain and we used IPV and it saved their life. No doubt about it, it saved their life because I had a patient who was satting 60, really sick, had no other chance of getting off the ventilator. And we had a therapist who did IPV next with that patient just continuously, constantly, as much as they could, and that patient recovered. And it was, we were looking at this patient thinking, chances of survival were 10%. So yeah, we've seen IPV be a good intervention in these patients. Yeah. We classify ventilator-associated pneumonia as pneumonia that after 48 hours of mechanical ventilation. It's not to say that aspiration couldn't have occurred earlier in other settings. When it occurs in other settings, we call it something else. If you have an alcoholic who goes to the emergency department and aspirates after you intubate them and then they aspirate, we call that aspiration pneumonia if they get sick later. If they have surgery, they come out of surgery, 2 days later they're at home and they have pneumonia, we call that postoperative pneumonia. So I really believe there's a common piece to this, which is all of these patients were intubated, and the breathing tube we know is a direct path for these pathogens. So the question is, are we really treating these different entities? Are these entities really all that different, or are they just different because of the people seeing them? and maybe the types of bacteria and the types of infectious agents that we, and so this is a very interesting point, is if we could institute some of these practices in other settings, could we reduce the incidence of pneumonia that gets imported into the ICU? And that's really fascinating. There's some work at the University of Washington, St. Louis, where respiratory care practitioners are doing mouthwashes for lung transplant patients days ahead of their procedure. As you know, lung transplant patients have a very high incidence of postoperative and ventilator-associated pneumonia. And so the idea is some of these interventions that work in the ICU, maybe we should be doing them days or even during the procedures to reduce this incidence, because we know how many of these pneumonias are caused, which means the same interventions that work in the ICU, if we can apply them in the ED and maybe the OR, should actually help. So excellent question. Thank you. Thank you. Oh, okay. Any more questions? So I'll be available if you like to talk, and if you like to see some airway devices, just come on by. So thank you so much.